Hello and welcome to another edition of Health Solutions with Shawn and Janet Needham, where Team Needham discusses everything healthcare. I'm your host, along with my beautiful wife, Janet, and our producer, Lindsay, and we are streaming from the Moses Lake Professional Pharmacy studio today, and we are going to be talking about breast cancer and breast reconstruction. We have Dr. Irena Karanetz.
Yes.
Yes, Karanetz on today, and she actually was fellowship trained in breast reconstruction, and that's kind of the direction she's headed. So she is very, very knowledgeable and an expert in this subject. And without further ado, Dr. Karanetz, I just wanted to let you introduce yourself, and we can start talking about this topic.
Yes, thank you, Shawn, and thank you for having me here on this podcast. And just a little bit about me. I did my plastic surgery training in New York, and then following that, I did additional fellowship training specializing in breast reconstruction as well as cosmetic breast procedures. So I'm definitely passionate about working with women with breast cancer patients. So when Shawn reached out about discussing this broad topic, of course, I jumped on it, and it's my pleasure to be here and just to help our listeners understand a little more what is breast reconstruction and what are some of the options that patients may have following mastectomy or breast cancer surgery.
Awesome. Well, I'm excited to have you on. I know this is a very, very popular topic. We work with a lot of patients in the category where the most common age of breast cancer, I'm assuming, is probably postmenopausal. Is that correct?
Correct, yes. So breast cancer is the second most common cancer in women. About 1 in 8 women will be diagnosed with breast cancer in their lifetime. Mostly, yes, postmenopausal in terms of the age group. So it's definitely breast cancer screening, breast cancer treatment, and then maintenance following breast cancer reconstruction. Those all are very broad and important topics. And one more quick thing I wanted to point out, that I am just one of the pieces of a puzzle in terms of taking care of breast cancer patients. So whenever we treat patients diagnosed with breast cancer, it's never just the plastic surgeon. There is the breast surgeon who performs the surgery. There is the oncologist, and who can help decide whether the patient needs chemotherapy. There is radiation oncologists that can help with radiation treatment. There are many social workers and physical therapists who help patients kind of navigate this system. They are called breast cancer navigators because it's a lot and it's overwhelming. So again, I'm just one of the many specialists involved in this holistic approach to treatment of breast cancer and breast reconstruction. And it's truly a multi-specialty and multidisciplinary teamwork. From the beginning, from the diagnosis till the patient has completed all the treatment.
Absolutely. Thanks for clearing that up. It's definitely a multidisciplinary team approach for sure. So, Janet, do you have any questions for her?
Well, before we get started, since we've had the pandemic, my concern for women is that we've skipped some screenings. So are you seeing that in your practice, that we've kind of let go of early detection? Should we be advising women to start ramping up and going back in and having their exams done? And what is your take on that?
Yes, I mean, definitely pandemic has affected patient care initially, when a lot of elective surgeries were placed on hold and patients were hesitant and scared to go to the office, to go to the hospital during the worst of the pandemic in spring especially. My practice that I'm part of, New York Plastic Surgical Group, we stayed open throughout the pandemic. So a lot of hospitals prioritized taking care of the cancer patients. So there were ways that our healthcare system tried to navigate the pandemic so that we don't neglect patients who have advanced cancers, even though our hospitals were so overwhelmed with COVID patients. So I think breast, and again, the more we became familiar with the virus and the pandemic, the more precautions were in place so that patients, get screened. The medical offices or screening facilities have their own protocols in place so that patients can have the proper follow-up and proper care. So I think where we're at now, Janet, that again, we're at a good place, that everything's kind of feasible, just with new guidelines, new precautions, safety precautions. But I think in general, our healthcare, I think we did well as physicians, trying to make sure that patients with cancers got proper care.
That's good to hear. So I guess relaying to our viewers, if you are putting off your screenings, call and make your appointment, because I think early detection would be optimal versus not. So don't put yourself on the back burner. Make those appointments.
Absolutely. Yep. The screening, and for a lot of women over 40, it's good to have a breast doctor that they follow up with, so that there is somebody following along for their routine breast screening.
So are you one of the, talking about a multidisciplinary team, so a breast surgeon comes in before you come into the picture, whether it be a lumpectomy or whether it be a mastectomy, is that correct?
Correct, yes. So typically what happens is, let's say a woman in her, let's say, early 50s, she has her routine mammogram annual, like Janet said, because that's what the guidelines are, and something comes up on that mammogram that's concerning. So then that primary doctor, or maybe it's OB-GYN, or she already has a breast doctor, gets that result, and then that usually triggers two things in terms of the reporting of breast findings on mammogram or ultrasound. There is a grading, and it's called BI-RADS categories, and it just tells us as doctors, the radiologists tell us how concerned they are about what they see on that image or on that mammogram. So then that triggers then either nothing or a mammogram in a year, if it's non-concerning, or if there is some question, then that can trigger a biopsy. And biopsy is something that sometimes radiologists do, sometimes the breast surgeons do, where they'll remove a little bit of tissue, and then that establishes the diagnosis. So then once we have the actual, from screening to imaging to diagnosis, now that's where surgeons come in. And first, of course, is the breast surgeon, who then sees the patient and has a discussion about options, and again, whether they're a candidate for lumpectomy, which is removing just part of a tumor where the tumor is located, or mastectomy, which is removing the whole breast. And then afterwards, then the patient sees a plastic surgeon to discuss what are my options following the surgical removal of breast cancer.
All right, so let's go ahead, if you don't mind, we'll go ahead and get into your presentation. Is that okay?
Yes.
Okay, so explain, well, you're going to say something. Go ahead.
Yes, no, so I was just going to say this presentation, I just tried to put a few slides together to, again, hopefully for our listeners to follow along, because it is a lot, and I tried to keep it simple. But again, now that, let's say we have the diagnosis that the patient has breast cancer, and now the breast surgeon then decides whether, and discusses with the patients, their options for mastectomy, which is on the left, and it's removing all the breast tissue, versus lumpectomy, which is just removing a small amount of tissue around the tumor. And lumpectomy is often followed by radiation therapy afterwards. Another important thing that for us as plastic surgeons is whether, after removing the breast tissue, what happens to the skin. Sometimes the nipple is removed as well. Sometimes nipple is preserved. That's been a newer invention, or not invention, development in terms of mastectomies, that there's some indications where we can preserve the nipple, preserve the skin, and just remove all the breast tissue underneath. And I like to tell my patients when I explain that it's like removing the pillow from the pillowcase, where the mastectomy, you remove that pillow, and now me as a plastic surgeon, I'm left with the pillowcase, which is empty. And now it's my job to discuss with them what are our options to fill in that pillowcase, to give them a breast mount, to give them a breast that they can go out and wear clothes and feel normal and whole and feel like a woman. So again, a lot of what I can do depends on what the breast surgeon decides in terms of oncologic treatment for the patient. And again, preserving the nipple usually gives the best cosmetic result, but not all the candidates, not all the patients are candidates for it.
I love the pillowcase analogy. That's a great analogy. So let's go ahead and move on to the next slide, Lindsay.
Yes. So then, now that we're back to our pillowcase analogy, and in terms of recreating that breast shape and breast mount, there are two ways, and a lot of patients and people are familiar with implants, which are typically silicone or saline breast implants, or using your own tissues, which are a little more advanced procedures that we do, and these are called flap procedures. So kind of, again, during what I would like for patients or listeners and patients to understand that those are the two ways we can go about it. It's either we use an implant, usually it's at least 2 stages, because first we often put in an expander, which is a temporary implant, and then we switch to an actual permanent implant, or using your own tissue, which most commonly it's using, everyone has a little bit of tissue, especially after having children, below the belly button, so we can recruit that tissue to reconstruct the breast. And obviously, some patients who are very fit, they may not have the tissue for us as plastic surgeons to transplant to the breast. So then we're kind of limited to using the implants. But for those patients that have extra tissue, it can feel more natural because it is your own tissue versus the implant.
So kind of a bonus, a thinner weight and bigger breasts.
Exactly. Yes. So it is. And now that we as plastic surgeons, of course, besides reconstruction, we were always trained to optimize the results. So when we do this type of reconstruction, we follow the principles that we do in our cosmetic breast surgery and in our tummy tuck surgery. And again, this has been all an evolution. I'll talk a little bit about these complex, these are microsurgeries, and like everything in medicine, as the techniques evolve and we all get better, the results, of course, get better. So flap procedures are definitely, free flap procedures is something that has been evolving and becoming more popular.
Awesome. So is there ever an issue of rejection of an implant? So would there be a reason? So would there be a bigger reason to go with your own tissue if you could?
Yeah, so that's a great question, and a lot of patients ask us the same question. So it's not that the body rejects an implant because implants are safe, but like any procedure that we do, there could be complications. So you may have an issue with an implant where, let's say, the wound doesn't heal and then that implant gets exposed, because it is a foreign body that we're putting in that thin pillowcase, right? So it's very sensitive skin after mastectomy. So sometimes things don't heal well. Sometimes you get an infection and then you may lose that implant. So it's not so much that your body rejects it, but it's just that combining the mastectomy and reconstruction, and we do it all at the same time, it just stresses the skin and the tissues a lot more. And then in terms of using your own tissues, along the concept, like you said, with rejections, again, it's your tissue, so your body won't reject it. However, when we transplant the tissue and we connect the small arteries and veins for the tissue to live, sometimes there could be a problem with, I guess, the pipes, we can call it that way, with artery and vein, where they can clot, and then the blood flow doesn't get to the tissues, and you can lose the flap. So again, it's not that your body is rejecting, but for us as surgeons, those are some of the potential complications. And of course, we discuss that with patients because no surgery is without the complications. So again, we're very good at breast reconstruction currently, but it's an important discussion that I have with patients as well.
So I believe we have a slide about this flap you're discussing, correct?
Yes.
Is it the next slide?
We have a little, I think maybe a few more.
Okay, let's talk. So we can talk about the implants first.
Yeah.
So you already did a little bit.
Exactly. So again, traditionally, when we talk about implants, everybody thinks about silicone implants. And something important that I want to point out that, both the saline and silicone implant, the shell is made of silicone. So even though some patients may say, oh, I want a saline implant, that's pretty much sterile salt water. That's what saline is. It's a water-filled implant versus silicone. It's a little more cohesive, so it maintains the breast shape better. But either way, the shell is made of silicone as material. And then in the next slide, sometimes the texturing varies, where on the left you can see is more kind of form stable implant, and it's got the rough surface, so that's textured surface, versus the one on the right, it looks smooth because it's non-textured. So those are the types of implants that we typically use.
Okay, is the next one the flap, or okay? Let's let's talk about the procedure under the muscle or above.
Yeah. So and so again, we'll go back to the pillow and pillowcase analogy. So that's just talking about the skin. And when you put in usually the expander, which is the temporary implant, there are two ways where we can put it, and it all depends on how the skin is after the mastectomy portion. Sometimes if that's skin envelope is in very good shape, then we can put an implant right underneath, which is the expander. And sometimes we have to put it under the muscle. So that's kind of the decision, again, that we make often during the surgery. And it's something that I definitely discuss with patients. So I like this diagram, and it's actually from one of my former attendings in training, that all the way on the right, you can see that the red tissue, the muscle. So you can imagine it just protects that implant more, right? Because now you have skin, the muscle, and then the implant. So if you were to have one of those wound healing issues that happen occasionally, you just have a little more protection for that foreign body, which is the implant, versus the one in the middle where it's right underneath the skin. So that's, again, those are the two ways where we can put during reconstruction the implant, whether we put it above or below the muscle.
That's a good visual. Thank you for providing that. Janet, do you have any questions?
No, it's really explained well. So yeah, I like the visual as well.
And then I think in the next slide, I had to mention this product, and I have no disclosures, but this is another support material that we use during reconstruction with implants. And again, I like the visual on the right because it just shows you how the muscle, the way our chest muscle is, it only covers the upper portion of the implant. So then the lower portion doesn't get much support. So sometimes we use this product. It's a skin substitute product to support that implant and the weight of the implant. And that's again been more so used over the past decade in breast reconstruction.
So go ahead, Janet.
Well, the question I would have is, this would be something you did after you did stretching with the tissue, right? You would put your insert, stretch the tissue, and then support it with this, or do you do it before?
So that's a good question. So usually that middle picture that you see where it has that white extra tissue and muscle on top, that would be at the same time as we're at the same time after the mastectomy, that the goal would be to put that temporary implant, make sure it's as well covered as possible. Because again, this is underneath the skin. So you have skin, then you would have the muscle, and then the implant underneath, and maybe a sling of this tissue, skin substitute.
That makes sense. So I should have asked this a little bit earlier, but let's talk a little bit about reconstruction after lumpectomy. So does every woman that has, I know it's a strong word, but do most women that have a lumpectomy, do they need reconstruction, or do they choose to have reconstruction?
Yeah, that's a great question. So maybe if you go back to that slide where it said mastectomy all the way at the beginning, yeah. So you can imagine if it's somebody, let's say if it's a woman who has large breast and a small tumor, taking out a small amount of tissue won't change her breast shape much. However, if you have a woman with smaller breasts and you take a big chunk of it, then they will have a deformity. So that's where, again, we as plastic surgeons come in for, we call it oncoplastic reconstruction, where we can move the remaining breast tissue, kind of like origami, to remobilize the tissues to close that hole, close the defect, so that when, after removing the tumor, it's a smooth contour of the breast, that there is no major depressions. And there are many different techniques that, again, have been developed to help reconstruct the lumpectomy defects as well. And that doesn't necessarily involve the implant, because again, this is just a small amount of tissue that's missing. So we like to say in plastic surgery, you replace like with like. So when small, you replace with the breast tissue nearby, and you kind of mobilize it and move it into the defect. So we talked about implants and lumpectomy reconstruction, and then again, reconstruction using your own tissues is traditionally you would use skin and fat that's attached to the muscle, kind of like in the picture on the left where you see the back muscle. It's latissimus, and then you see the muscle, and then there is skin and fatty tissue from the back that's used to replace the breast, or the same was used from the abdomen. So the drawback of this operation, one of the drawbacks is that you take the muscle, right? And muscles are functional. So whenever you take muscle from one part, there may be some deficit or weakness, like in operation on the left that can affect arm movement, and the surgery on the right where you take one of your abs or rectus muscles that can affect your core strength and cause weakness of the abdomen. So then the invention of microsurgery came in, where rather than take the muscle, we're able to transplant the tissue, which is skin and fat, from different parts of the body on its blood supply, then connect it to the blood vessels in the chest, an artery and vein, to reestablish the blood flow. And that way you get living tissue it's your own living tissue that's transplanted from where, like you said, where you have extra tissue, like your lower belly, or let's say it can be your inner thighs. Again, all with principles of cosmetic surgery where the scars are well hidden. If it's the belly, it's like a tummy tuck incision. If it's in the inner thigh tissue we take, it's more of a thigh lift incision, but it still allows us to take this tissue, skin, and fat, which is very similar to breast, which feels like fat too. And then using either microscope or special magnifying loops, we connect these 2 millimeter blood vessels, and that way we transplant the tissue and you get reconstruction with your own tissue. So that's called free flap breast reconstruction versus muscle flap that I mentioned earlier, that traditionally you didn't do the microsurgery, you just kind of rely on the blood supply that goes through the muscle and then to skin and fat.
Wow, that's a super cool procedure.
Yeah.
That's yeah. I'm sure that 2 millimeter using a microscope and wow. I mean, that's you got to have some pretty steady hands, I suppose.
Yes, that steady helps and that goes back to the fellowship discussion that we mentioned earlier, because as you can imagine, this is specialized surgery. Not all the medical centers, not all the hospitals have capabilities for this advanced surgery. And also as a surgeon, you want to have extra training so that you can safely and efficiently do these procedures and offer those to your patients. So that's why I did that extra year of training to, again, make sure that I'm proficient in those operations as well, so that I can help my patients who are good candidates for this operation. So if you go to the next slide.
There we go.
These are the areas. Yeah, I just thought it would be fun to add the picture with the magnifying glasses. So we either use a big microscope to sew in those little blood vessels, or use these magnifying glasses that I have on and special headlight to do the same microsurgical procedure. And on the right, I like the diagram just because it shows the areas, like I mentioned, where you may have that extra tissue, extra roll of tissue that we can harvest on its blood supply and end up with minimal scarring while being able to reconstruct the breast. And again, it could be from the back, it could be from the tummy, it can be from the buttocks region, it could be from inner thigh region. So those are most commonly, it's typically from the abdomen, from lower abdomen. And then that's the deep flap procedure. And in deep is just a fancy, a long term for deep inferior epigastric perforator flap. But I think the easiest, and I think I love this diagram because it shows exactly the purpose of the operation, where you take that skin and fat, that's extra hanging skin, and then using special microsurgical techniques, you separate it on its blood supply, which is that artery and vein going down, and then when you cut it, as you can see in the right upper corner, it's now it's dead tissue. So the only way to make it living tissue is that you got to reconnect those two pipes, those two little 2-3 millimeter pipes so that the blood flow starts flowing. And that's the microsurgical part of the procedure. So after we take that tissue from the belly, the lower abdomen is closed in a tummy tuck fashion. And then we bring this tissue that feels like breast to the chest to reconstruct the breast. And I think in the next slide, this is very important because, as you can see, we're not taking the muscle, right? So that's the difference. We take skin and fat on its blood supply, and then we transplant it into the chest. So that preserves that muscle strength and improves outcomes. And then we connect it to the chest vessels, again, to the tiny artery and a vein in the chest, and then it becomes living tissue. And that's a short version of of a deep flap or free flap from the abdomen procedure.
That's really cool. Thank you for sharing that with us. Janet, do you have any comments or questions?
Well, I think that looks amazing. I helped women for many years with prosthesis, and that to me, the being able to use your own tissue is just a incredible advancement I think that is just amazing. So I guess a comment, not question. Right. I loved seeing the outcome of that. After seeing several women over the years, mm-hmm. You can see the advancements that have happened. So that's awesome.
Yeah, it's wonderful that we can offer that to patients now too. And again, it's definitely a bigger, more tedious operation, as you can imagine. Yeah. Requires a team approach and a medical center where we can do it, but it's not, now that it has become routine, it's not such a big endeavor as it used to be 10 years ago. So again, these are all advancements, and I'm glad I could share some of these things with you guys today.
Yeah, thank you for sharing those and your expertise. Our listeners and viewers really appreciate it. So, as we're wrapping up, what is, Dr. Karanetz, what is your passion? What drives you?
What drives me? At the end of the day, it's happy patients. And to me, no matter how many hours I work a week, or I've done over 16 years now to get to the point where I'm at. But when I see a happy patient whose life I had helped transform, and then they come into me and come to see me for follow-up, and they are more confident and they're glowing. And for me to be part of their journey, to know that I was their surgeon, that they chose me, whether it's for elective surgery or for reconstructive surgery, or if I get to meet their significant others when they come for follow-up, it's very special and meaningful, and it's an extremely fulfilling but very demanding job. And I don't think you could do any of these long operations or do all of these things if you're not truly passionate about it, passionate about taking care of patients, passionate about doing the right thing. And again, whether it's cosmetic or reconstructive surgeries, it can be truly life-changing for patients on many levels. And it's a privilege for me to be part of these patients' journeys.
Well, that's awesome. So how do people find out more about you? What's the easiest way to get a hold of you?
Yeah, so it's pretty easy these days. Even on Google, you can always type my name, Irena Karanetz. It will take you to my website where you could see some of the procedures that I do, some of my before and after results. So we can definitely, I can definitely share that with you. But and again, I think right now, especially with pandemic, something amazing that came out of it is yes, if you pull it up, is virtual telemedicine,
right?
Virtual consultations. So I think if you just go to maybe Meet the Doctors, and you'll see Shawn, my name there. Mm-hmm. And again, the virtual consultations
there she is.
Are helping patients answer questions, or if they've had something on their mind. It's an easy way to connect with me as a surgeon. And again, whether it's cosmetic or reconstructive, it's easy to schedule an online virtual appointment, as you can tell, or call the office. And I'll gladly be there to answer any questions that patients may have.
Awesome. Awesome. Well, we appreciate you being on today and sharing all your knowledge and expertise. And as always, Thank you for listening to Health Solutions with Shawn and Janet Needham. Tune in Thursday for Dr. Garnita. She's going to be talking about autoimmune disease and how it affects our hearts. You don't want to miss that. Actually, Wednesday. It'll be Wednesday. Sorry about that. So tune in Wednesday. Check our Facebook, the Mosaic Professional Pharmacy Facebook and YouTube site for more information. As always, thanks for listening to Health Solutions with Shawn and Janet Needham.